anatomy. All right. So, okay. So when we're talking about larynx, everyone know where larynx is. Is the most anterior structure in the midline of our neck. Okay. So it lies opposite C3 and C6 vertebra, and larynx is extend vertically from the tip of the epiglottis to the inferior border of the cricoid. Okay, so we all know. Apparently, our larynx can be slightly higher in female and also in children. Okay, so there are 9 cartilages of the larynx that is connected by joints, ligaments, and membranes, and it is moved by 8 intrinsic muscles. Okay, so we'll go through that one by one later. So this is our laryngeal framework. We have the thyroid cartilage just below the hyoid bone, and then we have cricoid cartilage, and then followed by the tracheal rings. So we have 3 unpaired and 3 paired of the cartilage. The 3 unpaired is the thyroid cartilage, which is the largest cartilage in the larynx, followed by cricoid and epiglottis. We also have a 3 paired, which is arytenoid, corniculate, and cuneiform. So this is how it looks like from the anterior and posterior aspect of the larynx. Okay, so let's have a look at the thyroid cartilage. So as I mentioned earlier, it is the largest cartilage in the larynx. Its main function, beside the attachment of the vocal fold, is also protect the larynx. Okay, so when later when you go into the procedures of the larynx, you will find that the thyroid cartilage will be very important landmark for you to do the laryngeal procedure. For example, if you want to do injection laryngoplasty, you will have to palpate the superior thyroid node, and also when you want to do medialization thyroidoplasty, you have to identify the thyroid lamina. Okay, so that one we will go through later. Okay, so the next one is the cricoid. So we know cricoid is the full ring, is a signet ring, and it encircles the larynx just below the thyroid cartilage. It is much thicker and stronger than the thyroid cartilage. Yeah. So the anteriorly we have the arch, which is slanted inferiorly, and then posteriorly we have a thicker part of the cricoid, which is the lamina, and it has the facets for articulation with the inferior cornea of the thyroid cartilage. Okay. Next is epiglottis. It is a leaf-like shape, or we say it's oblong in shape. It's attached to the the inner surface of the thyroid lamina, and then superiorly it has this called hyoepiglottic ligament that attaches the epiglottis to the hyoid bone. Okay, so the major function of the epiglottis is to prevent aspiration during swallowing. Okay, so we have the lingual surface of the epiglottis, which we can see here that it has attachment via median glossoepiglottic folds. Okay, so next we have arytenoid. So arytenoid is pyramidal shape, triangular, and it has its base and its apex. And medially it has vocal process, and laterally it has muscular process, and it provides attachment for vocal ligament and major intrinsic muscles respectively. So the base of the arytenoid, it articulates with the cricoid lamina. Okay, so just above the arytenoid, we have a corniculate cartilage. These are paired and sits on top and move together with the arytenoids. And it is covered by the soft tissue of the AE fold. So another one is the cuneiform, which is a very small fibroelastic cartilage, sits laterally to each part of the arytenoid, completely embedded within the vocal fold. So the function of these small cartilages is basically to provide additional structural support to the AE fold. Okay, so the laryngeal cartilage can be divided into 2, which is hyaline and elastic cartilage. Hyaline cartilage is thyroid, cricoid, and arytenoid, which is it may ossify after 25 years of age. However, the other elastic cartilage normally does not ossify. Okay, so we have done with the laryngeal framework, so we go into the joints. These are the two major joints of the laryngeal framework, which is cricothyroid joint and also cricoarytenoid joint. These are synovial joints, and it provides rotatory movement around the transverse axis and also vertical axis. So beside the joints, we have membranes and ligaments. Membranes and ligament can be divided into extrinsic and intrinsic. So for extrinsic, we have thyrohyoid, cricotracheal, and hyoepiglottic. And for the intrinsic, we have quadrangular membrane with vestibular ligament and also cricovocal membrane and vocal ligament. So we'll look into that shortly. Alright, so this is the picture of the extrinsic ligament. We can see this is the thyrohyoid membrane, which attach the hyoid to the superior border of the thyroid or cartilage. And then we also have cricotracheal ligament attached between the cricoid and the trachea, and hyoepiglottic ligament. Right. So move on to the intrinsic. It is part of the fibroelastic membrane, and it just lies outside the mucous membrane. So what we have is we have quadrangular membrane, which contain the cuneiform cartilage. It extends from the area epiglottic fold between the arytenoids and also the epiglottis. And we have the vestibular ligament, which is formed from the inferior margin of the quadrangular membrane. All right? And cricovocal membrane, which is attached inferiorly to the arch of the cricoid cartilage and ends superiorly in the free margin. So all this membrane and ligament provide more support to the laryngeal framework. Okay, so I did come across a very nice 3D model when I was preparing for my slides. So maybe I can share with you the link later. Just hold on. Okay, can you see that? Okay, so this is what I found online, which is quite nice. It's a 3D model provided. I saw that in the website of the University of Dundee, where you can flip around the 3D model to see how the laryngeal framework looks like. Yeah, so I find it very interesting. So you can scroll, and they are numbered and they are labeled there. So for example, this is laryngeal prominence, and then you can also identify the superior thyroid notch and inferior thyroid notch. Then they have the lamina of the thyroid cartilage, hyoid bone, cricoid, and then they also flip around the back and shows a 3D version of the laryngeal framework. I can share this later, then you can play around this later. Okay. Great. Okay, all right. So we move on to the next one. So larynx is further subdivided into three areas, which is supraglottic, glottic, and also subglottic. So supraglottic, it started from the tip of the epiglottis until the superior border of the vocal fold. And then the glottic area is from the superior border of the vocal fold until 1 centimeter below the true vocal fold. And the subglottic started from inferior border of the 1 centimeter below the vocal fold until the inferior border of the cricoid cartilage. Yeah? I think some books use 0.5. Yeah, but I will use 1 centimeter. Yeah. Okay. So next we're going to have a look at the anatomy of the nerve innervation in the larynx. So as we know, recurrent laryngeal nerve is the main nerve that supply our larynx. And in the next few slides, the courtesy from my medical officer, Dr. Arif Sobani, which is very good at illustration and animation. And I will be sharing his work in the next few slides. So when we want to, if we want to talk about recurrent laryngeal nerve, of course we have to talk about the vagus nerve. So the vagus nerve lives the surface of the medulla as the rootlets. Then it unites as a single compartment before it enters the jugular foramen. Yeah. So before it becomes a recurrent laryngeal nerve, it gives branches like meningeal branch, auricular branch, pharyngeal branch, and also superior laryngeal nerve, which later further divided into internal and external. So recurrent laryngeal nerve travels downward in the carotid sheath, and then it gives rise to left and right recurrent laryngeal nerve. So for the left recurrent laryngeal nerve, it hooks around the ligamentum arteriosus just beneath the arch of the aorta, and then run back posteriorly to the left common carotid artery. So if you can see, the course of the left recurrent laryngeal nerve is much more longer. That's why it is more prone to injury compared to the right recurrent laryngeal nerve. So right recurrent laryngeal nerve hooks around the right subclavian artery, and it runs posterior to the right common artery and then it ascends in the groove of the trachea and esophagus, runs behind the cricothyroid joint, then deep into the inferior constricted muscle. It enters the larynx between the inferior cornu of the thyroid cartilage and the cricoid cartilage. So recurrent laryngeal nerve innervates, it gives sensory innervation below the vocal cord, while the superior laryngeal nerve, the internal branch, gives rise to sensory innervation above the vocal cord. So recurrent laryngeal nerve innervate laryngeal intrinsic muscle. For example, we have lateral cricoarytenoid muscle and transverse arytenoid muscle, which is the adductor of the vocal cord. So lateral cricoarytenoid is a very strong adductor of the vocal cord. So another intrinsic muscle that's supplied by recurrent laryngeal nerve are posterior cricoarytenoid, which give rise to the help with abduction of the vocal cord, and then vocalis and thyroarytenoid muscle involved in shortening and relaxation of the vocal cord. So exception, we know only one intrinsic muscle which is not supplied by the recurrent laryngeal nerve, which is cricothyroid muscle, which is supplied by the external branch of the superior laryngeal nerve. So beside intrinsic muscle, we also have extrinsic muscle of the larynx, which is suprahyoid muscles and infrahyoid muscles. And the main function is to control the vertical laryngeal position, basically to depress and elevate the larynx. It also provides laryngeal stabilization in general. Okay, so next we move on to the function of the larynx. So as we know, the main function of the larynx is to protect our airway. So if there's any foreign body that try to enter our airway, we will remove it by the cough reflex. Yeah? And then the next function is for respiration, where it becomes the conduit to bring the air into the lungs. And then the third function is phonation. So we're going to cover this function in more details. Okay, so as we know, phonation is a process of producing intelligible sound and speech. It involves three stages, which is production of the airway, production of the sound, and also articulation of the voice. So in order for you to produce phonation, it involves three systems, which is resonatory system, phonatory, and also respiratory system. Okay, so as we know, respiratory system is very important because it becomes a reservoir before you can produce the sound. Okay, so histologically, we know that vocal fold contains 5 layers, and this complex microanatomy of the true vocal folds allow the loose and pliable superficial mucosal layer to vibrate freely over the stiffer structural layer. Okay, so the most superficial layer is stratified squamous epithelium, and deep to it there are 3 other layers, which is intermediate, intermediate, deep, and also vocalis major. Okay. So the most superficial layer, superficial lamina propria, is mostly acellular and composed of extracellular matrix, protein, water, loosely arranged collagen fibers, and elastin. Superficial lamina propria is gelatinous in nature, and there's a potential space between superficial lamina propria and intermediate lamina propria, known as Rinke space. On the other hand, intermediate lamina propria and deep lamina propria composed of collagen and elastin, and deep lamina propria mostly composed of tightly arranged collagen fibers. So intermediate and deep is also known as vocal ligament. Well, so what happened is the gelatinous superficial layer of lamina propria together with the squamous epithelium moves freely over the vocal ligament and muscle to form vibration and production of sound. So this is what the mucosal wave looks like during phonation. If we visualize the vocal fold using laryngoscoposcopy, there'll be more video stroboscopy on the subsequent lectures. Okay, so now the last topic is physiology of phonation. So when we talk about physiology of phonation, we have to talk about the glottal cycle, which consists of 4 phases, which is opening phase, open phase, closing phase, and also closed phase. So this picture is everywhere on the internet and in your textbook if you want to talk about phonation. So this is what it shows in the one glottal cycle. Basically, the process begins with inhalation and subsequent glottal closure by laryngeal muscles. So once the air pressure builds up beneath the vocal fold, shown in picture 1 and 2, once the subglottic pressure is high enough to overcome the resistance, air is allowed to escape between the vocal folds, starting with the opening of the inferior lip, shown in the picture 3, picture 2 and 3, followed by the superior lip. So once the air escapes the vocal fold, they give rise to low pressure, which produce the Bernoulli effect, which causes the vocal fold to close again, starting from the inferior lip followed by the superior lip. This also occurs due to the elastic recall of the tissue itself. So the escaping air is then converted to sound by our resonator, which is our soft palate, our tongue, our teeth, and our soft palate. So any change that affects this mucosal wave, for example, there is a stiffness in the vocal cord, or any weakness or failure of closure or imbalance between right and left vocal fold from a lesion may cause voice problem. So the main complaint would be for hoarseness. Okay, so in 1974, Minoru Hirano introduced cover and body theory to explain the vibratory properties of the vocal fold. So we know that our vocal fold consists of 5 layers. However, to make it simplified, in the cover and body theory, they are divided into 2 primary layers, which is the cover, consists of superficial, including epithelium and superficial lamina propria, which is responsible for the mucosal wave and vibrates freely during the phonation. So the other one is body, which is deeper, more rigid layers, including of the vocal ligament and the thyroarytenoid muscle. So basically, this part of the body provides mass, tension, supporting the movement of the covers. So the simplified concept of the theory of the body theory, of the cover body theory by the Hirano, basically it explains that how the cover vibrates over the body to produce sound, with the body providing the necessary tension to modify pitch and loudness. So the interplay between the flexibility of the cover and the stiffness of the body allows for a wide range of the vocal expression. So the next slide, I want to show you the video about the physiology of phonation, so you will understand further about the glottal cycle. Yeah.
The human voice is created by air passing between the vocal folds, causing them to vibrate, resulting in sound waves. The vibrating vocal folds can be easily visualized with an endoscope passed through the nose. With such a top-down view, the vocal folds appear to be V-shaped thin membranes that vibrate against each other. However, such a simplistic two-dimensional view is actually incorrect. Rather, when the vocal folds are seen in cross-section, instead of being a thin band-like structure, they are actually a wedge-shaped triangle. Furthermore, when the vocal folds vibrate against each other, there is both a horizontal and vertical component. With phonation, the thyroarytenoid muscle first sets the vocal folds into a closed position. The vocal fold vibration itself is then due to the vocal fold membrane that overlies and moves freely over the muscle. Subglottic air pressure builds up below the vocal folds as air is pushed up from the lungs. The minimum air pressure required for initiation of vocal fold vibration is known as the phonation threshold pressure. The higher this pressure, the higher the potential for vocal hyperfunction. As the subglottic air pressure increases, it overcomes the resistance of the closed vocal folds, causing them to open slightly beginning from the lower margin. As the air pressure continues to move upward, more of the vocal folds open up until it reaches the superior margin, at which point, air is fully released between the vocal folds and pushes on up towards the pharynx. At this moment, airflow increases and accelerates as it passes the glottis, resulting in a pressure drop due to the Bernoulli effect. This pressure drop causes the vocal fold membranes to be pulled back together. As the lower edges of the vocal fold membranes come back together, they drag the upper edges to the midline since they are connected and share the same elastic properties. It is at this point that full closure of the vocal folds occur. The cycle is then repeated. It should be emphasized that this vocal fold oscillation is inherently asymmetrical, with a lag between the bottom and top edges of the vocal folds coming together. The vocal fold membrane or cover moves freely and separately from the vocal fold muscle as a result of the action of the air flowing through the glottis. This movement is wave-like, like a ripple over the surface of a pond, and it is known as the mucosal wave. Please keep in mind that the prior animation was exaggerated for clarity. In reality, the thyroarytenoid muscle does not move during vocal fold vibration as shown in this simpler animation. Note how the vocal fold membrane moves freely over the muscle. As the pitch increases, the vocal fold vibration speeds up as well as narrows together. The three-dimensional components of actual human vocal fold vibration can only be observed on high-definition, high-speed video recordings. Here is a video, courtesy of Dr. Eric Forrest. Please note that the video is silent.
This is the laryngostroboscopy. That's why you can see the slow motion of the vocal fold. So you can see the vocal fold become longer from when the pitch glide from low to high. Okay, I think that's the end of the video, and also
The human voice is
the end of my lecture. All right, thank you.